So this is my femur fractures I started and then decided that I loved the hip joint. So I do hip preservation, which is birth through young adults. As I get older, young adult now is 55 and 58 and younger. Next year it'll be 59 and younger. So, but basically it's birth through the 40s. Okay, so pre-arthritic hip. Which I include pediatric. And as a pediatric orthopedist, it was great to do that, but now that I do young adults, I can see the end of the chapters. So it's nice perspective. Who here sees and screens for baby hips? So a couple. Who sees in sports medicine pre-arthritic hip? Okay, so any hip arthroscopists? Is hip arthroscopy growing in your areas? Slowly, right? That's why our reps are here, but no. So hip arthroscopy is taken off in North America and some in Europe. It's a little more muted. But again, like anything, took off too fast. And now the reason I travel and educate is to try to say, when is this wonderful tool useful and when is it not? And it's usually dysplasia is the thing it comes up against, okay? So we're going to start with the babies. So osteoarthritis of the hip is a result of mechanical overload of deformities which can oftentimes be improved. The major factor is loading of the acetabular rim by instability, or in some case, that's what we're going to talk more about, or impingement. Most have developmental causes. So DDH used to be congenital dislocation of the hip. Does anyone know why it changed? The lawyers. So, because if you found it, well, it should have been picked up at birth, okay? But if it's developmental, it has less of a birth defect thing, and so perhaps you could miss it. That's sort of a skeptic's view, but they did go from CDH to DDH, which is developmental. It can be dysplasia, or it can be dislocation, or it can be both, okay? So DDH is anything where there is not enough support of the acetabular over the femoral head. So it encompasses all stages from an abnormal acetabulum, instability, subluxation, dislocation, version, all these things. So here's a true dysplasia. This is the femoral head dislocated in a newborn. And this is instability and dysplasia, where even though the sourcea is flat, the volume of this acetabulum is not enough in this female with ligamentous laxity to support the femoral head. So you can see in a given day, you see all versions. It's an abnormal load to the acetabular rim in the skeletally mature person where all the forces are here, and you can get injury to the rim, labral complex, and eventual osteoarthritis. So incidence in general is 1 to 3% of newborn infants. Hip instability is the single most common abnormality in infants. Unless you take all of cardiology together, it is the most common. So the pediatric specialties, I think, should focus more on it, and perhaps that would be good. And who has screening in their country that is selective, just for those with risk factors? Who has universal ultrasound screening? Yeah, you guys are much more advanced. So 0.2% of newborns have hip instability. Like the Orlani and Barlow are negative are positive at birth. So again, like 0.2% have Orlani and Barlow positive. But the challenge is 90% of adult DDH is not detectable with traditional newborn screening. And that's more like our selective screening, those with risk factors, those with abnormal exam, okay? The question is now with universal screening, will that number be less? Or are the deformities at the end of growth that lead to this? So the etiology, it's genetic, environmental, hormonal, okay? So there's a 12 times increase in DDH in first degree relatives. So if you have DDH or a mother has DDH, you have to look at the child. If one child has dysplasia, 6% in the second. If a parent has dysplasia, 12% risk in the child. And if one parent and child, it's 36%. Okay, so These are percentages that we know. It might be different if we screened every child in the world in different cultures. Perhaps these numbers would be different. So it's usually a shallow acetabulum with capsular laxity, an intrauterine environment. The reason breech is because the leg is stuck against the sacrum, their head's down, and if you can't move the leg like arthrogryposis, the hip doesn't form normally, okay? And the postnatal environment and genetic factors. So current efforts for prevention of hip dysplasia is focused on early detection and early intervention. It's a plastic thing at that time. If you can detect it early and do early intervention with Pavlik and bracing, then perhaps that's best for the hip. In many cases, hip dysplasia may be secondary to the postnatal environment, okay? So neonatal ultrasound has indicated, like in a very, very young, 2-month or second trimester patient, more of the hips are normal then, and as they get older and bigger, that's where we start to see some of the dysplasia, the factors that contribute. So human infants have an average flexion contraction of 28 degrees. They're all born like this. So I used to go to the neonatal unit and see all these babies in a burrito with the legs out in like this in a papoose position, and what it does is it forces that hip, because the abductors are contracted for a couple years, and then you force the hip into extension, and whoop, it just comes more lateral, okay? So we do not swaddle in extension anymore, and the reason you swaddle is so the baby can feel like they're still in the intrauterine environment, and they're never in like this, they're always in like this. So that's the best way to swaddle. So avoid extremity tight swaddling. The rate in Japan went to 1 to 3.5% to 0.2 when swaddling changed, okay? So they like to swaddle like this? Yeah. So one of the things you guys can do to help hips, we'll just do this right here, is you can go to the nursery and say, we know this is true. We have to have loose swaddling of the legs to decrease the hip dysplasia rate. But there are some countries that it's more genetic. So especially where some of you are from, like in Poland and stuff, the hereditary is worse. In actually, I'm speaking to the crowd in the region where it's just genetically more common. But you can make it worse if you swaddle the wrong way. So that would be something to take back. There's a couple papers on it. You can show the pediatricians, you can show the nurses, and perhaps change hip dysplasia for this group of children, or make it better.
It is a family problem. in some villages, they use it because they are big families. The mother-in-law, the bride, and everything. They say, "You have to swaddle the baby."
Well, you can swaddle the baby, but leave the legs clear.
The legs.
Okay, so the goal of early screening is decrease the rate of undetected newborn dysplasia and theoretically skeletally mature hip surgery and arthroplasty. Early detection and treatment with non-operative bracing has a better outcome than later operative treatment. I think that's obvious. So here's a patient, actually, there's their ultrasound, and it was read as normal, and this is what they showed up as an adolescent. So the goals of treatment: we do know a poorly centered hip will not last a lifetime. Just like the tires on your car need to be balanced so the treads last longer. You want to find DDH at the earliest possible time. Early, the biologic plastic hip can be improved, okay, by positioning the femoral head in the acetabulum. Allow the two to grow normally together. Dysplasia alone, though, can be silent and therefore difficult to detect. So, at least in North America and Canada and some countries, the current screening practice, is it effective in impacting the burden of disease? I would say only partially. If we had universal screening, this 2-year-old would not show up and I wouldn't do surgery. During COVID, the exams got worse too. They were all telehealth. So I saw in the last couple years a lot of 2 to 3-year-olds that weren't screened effectively and came in with dislocated hips. And so that COVID just took it and made it worse. But would screening impact this hip? Would this be normal at birth? That's still an unanswered question. So here's universal screening. It may have changed, but these countries, some of you are from, But I don't know anybody, Netherlands, Belgium, France, Portugal, Sweden, and Norway, at least at the time, still had selective ultrasound screening. So even some European countries still have selective, and England, selective ultrasound screening. So I would say that these countries seem to be more advanced as far as picking it up. So the selective screening strategy, every child gets a clinical screening exam. I don't care if you have selective or general ultrasound screening, you need to have a clinical screening exam that is a good Orlani and Barlow, okay? Limited abduction matters and leg length discrepancy you look for. So if a child shows up at 9 months of age and the leg is foreshortened and externally rotated and seems shorter, you listen to the family saying it's shorter, you examine, and you screen the hips. Because usually the late ones found it's because they're waddling gait and everybody's like, oh, it's just a pediatric, it's just a little kid, they walk funny. Always check the hips because perhaps there's a dysplasia. And almost every of those 2-year-olds that show up have warned their pediatrician and their orthopedist, their screener, that something's not normal. So you have to think about the hips, okay? Selective ultrasound screening in those with risk factors, which are breech, family history, and abnormal exam. So it's not a family history of dysplasia. So if you have a mother who has a hip replacement, oh, but they didn't have dysplasia, you don't know. So any disease. So when we went from dysplasia to include any hip pain or disease, the percent went up. So if they are burdened by the hip, then you have to think of dysplasia. Swaddling is now recognized as a risk, but it's not popularized and it's not in our guidelines at this point. So we have, again, I'll bring up the AOS guidelines. American Academy of Orthopedic Surgery is a big institution, but they have certain guidelines about selective screening, and they say breech, family history, and clinical instability. The recommendation was based on 2 prospective randomized clinical trials from Norway to support selective screening when used in conjunction with high-quality clinical screening. The problem is these people that were in these 2 studies were in a study and they had to pay attention to their clinical exam out of probably more than somebody that would just be in the office. So you're talking about excellent screening, they had to document it. It's not just a busy day, this is a study patient, and then did the study from there. So it makes a cohort that's a little bit more, perhaps better screening. So universal newborn ultrasound screening is not recommended, at least in these countries, because of the expense, inconvenience, inconsistency, subjectivity, and high false positive rates given an overall population disease prevalence of only 1 to 2%. So they're like, only 1 to 2%, so we shouldn't spend all this money on this. And then in some systems like ours, who's doing the ultrasound? Is it normal, abnormal in these population and city centers, which you still may have in general screening. So is the ultrasound sonographer good? When it's read as normal, but it's really not abnormal to somebody else, does that person then show up later? So it's really, you have to have very good ultrasound centers and screening centers to make it work. So this is one of the studies by Rosendahl in pediatrics, and they found the prevalence of late diagnosis was lower in those with general screening versus selective. When I mean selective, it's those with risk factors, ultrasound screening. General screening is everybody get ultrasound. Does that make sense to you guys? So selective screening, but it wasn't statistically significant because you didn't have big numbers, right? And here's the second study. These are by the Norwegian study, is there was 1 late detected in the universal ultrasound screening group, 5 in the selective, but it wasn't statistically significant. It didn't reach the 0.05 theory. So to me, that's significant though, those 4 kids. But it requires a very good exam and adherence to protocol. Specific care was given. Does that make sense to you guys? So these are study patients. So again, it doesn't reach significance, but in countries that do general screening, the late detected and the open reductions of the hips have decreased dramatically compared to selective. Also, I will talk to my friends that do hip preservation in these countries, and the PAOs and early DDH surgery has gone down. Finally, they're starting to see a difference. So I think it matters. So what is the predictive value of breech in DDH? You still need, whether you have selective or general, you need to know the risk factors. So DDH is present to some degree in almost 1/3 of breech hips at 6 weeks. So if you're really critical with the x-rays. Treatment was required in those that treat really mild deformities in 1/3 of the patients at 6 months in breech. So radiographic DDH is possible even if the 6 to 8 week ultrasound is normal. Okay, so a lot of places now, if I have a baby hip that comes in with a normal ultrasound because of their breech, I will get an x-ray again at 6 months or 1 year. Not quite yet at 4 to 5 years, but theoretically that's because it's a risk factor, the breech, okay? Breech presentation is still a risk factor and requires ultrasound screening. So if you know the patient didn't get it, their breech, they should be ultrasound screened. Family history is a significant risk factor for in all recent literature. So I did a recent literature search. Family history still is. First degree relatives have a 12 times risk of DDH over the controls. And the term family history of DDH, when asked, may be too narrow, and perhaps it would be better to inquire, has anybody had treatment of the hip? So female is the biggest risk factor. Firstborn is not. I used to think firstborn female, but when you look critically at it, it can be secondborn, thirdborn. So female is the biggest risk factor. Firstborn is not. Hip clicks and asymmetric thigh folds may be a common reason for referral, but there's no correlation with DDH. A click and a clunk is different. A clunk is when it's out and you can feel it go in. Clicks are from anywhere, knees, anything. But if they're referred, so if they come to me, I get an ultrasound screening. I just do it. It's easy to do. Does anybody here do their own ultrasounds, or were trained in residency to do their own ultrasounds? Yeah, it's not that hard to do. So when they looked at England, 50% of late presentations do not have traditional risk factors and would have a normal exam. So 50% are missed unless you generally check every child. Although current screening may decrease the operative treatment rate, selective screening still results in late cases requiring surgical treatment and may have little impact on the incidence of DDH. So again, this lecture was derived talking to the people that I usually talk to that have selective screening. So it's nice to talk to the general group because I think it's important. The Norwegian Registry on Total Hips, 92% of young patients requiring hips were undetected during childhood screening. And this is, in Norway, they keep good contracts. So the majority of the hips mild dysplasia group, you probably might not pick up during screening. Only 15% of our PAO patients would have been screened as infants. So there's still maybe 2 diseases or one disease, and some are easy to pick up when it's obvious at birth, and some maybe you can't pick up till the lateral acetabulum doesn't fully develop. It was proposed that they're 2 different things. Baby hips dysplasia with dislocation is different from the 22-year-old with a decreased center edge angle that sees you. And it's really maybe a spectrum of the same disease, because when we looked at CT scans of those treated versus those untreated, the CT scan measurements were the exact same. So perhaps it's a spectrum of disease. So PAOs and early OA from DDH is decreasing in countries, like I said, where there's universal screening. So it has made a difference. But what's more important, a good physical exam and selective ultrasound screening is a minimal requirement. So when you get a baby, or your partners do, Ortolani and Barlow, what are the risk factors? This is your one opportunity to perhaps treat them. We can improve the education adherence to screening protocols. So that's the other thing that was lost during COVID is the education and the importance on that part of the baby exam was kind of, because it requires an in-person exam in a very quiet setting, which doesn't happen very often. So how do we make the diagnosis of young DDH? We want to combine risk factors and exam to increase the awareness. So newborn DDH is easiest to diagnose. A late diagnosis, not missed, always call it late, is much harder, okay? So Ortolani, does everybody understand the Ortolani? So O means out to me. That's how I remember it. I have mnemonic. So it's out, you put it in, okay? The way to do it is you don't squeeze really hard. You hold the leg out, the other leg out. I like to hold the leg out and then just feel with my finger and, in and out. You sort of, it's not like it's more of a, like this with a soft wrist to see if it pops in, pops out, fingers under the trochanter, okay? I treat all those right away. Some might wait 6 weeks. This is harder. Barlow, it's in and you can feel it come out. So maybe it's more sublux, maybe it's out. These might normalize on their own before you see them. So how do you get the best odds of diagnosis? Well, you need a slender, well-fed, sleeping, warm baby. which is definitely in a quiet setting. I imagine that's all our clinics, right? But not really. So it's hard to do. You observe the resting position. Is one leg in, one leg out? So you get pattern recognition. You look at risk factors, those with torticollis, club feet, or metatarsus adductus. Those are high because they're packing disorders, so they imagine the hip didn't move as well. Okay, examine the hip first because that's before they start screaming, and that's where you can get the exam. So lowering the odds is a crying hungry or tense baby, hurried doctor, inexperienced, too firm a grip, misunderstanding of the test, or the exam is not consistent. So newborn nursery diagnosis. You get called to the newborn nursery. Okay, refer to the treating physician, try to do it in the next 2 weeks. Discuss with the family, if you have a dislocated hip, that what you're doing is conservative treatment to normalize the hip so when they're an adult, they have less chance of, like you, less chance of hip pain, okay? This is a preventative treatment for 15 to 25 years later. So if you do that, usually it's newborn families and they were born with a defective child and you're like, no, we can make this normal. This is 1 to 2%. We can normalize this with a Pavlik and then they'll buy into the treatment. A hip click, no association with dysplasia. Double diapering, so sometimes when the ultrasound is immature, so that's the first 4 to 6 weeks with a slightly decreased alpha angle that you're gonna follow, I will put a second diaper on there. And it just keeps the legs abducted. It's not necessarily a treatment, but it's just a reminder. So sort of here is the newborn, no risk factors, normal exam, no suspicion. Usually nothing's done or a general screening is done. But if they have risk factors, inconsistent exam and associated conditions, you have a high suspicion for DDH. So of those with general screening in this room, how many do it at birth? Like in the hospital? So in Germany, they do it the first week in those with risk factors, and then they do it at 4 to 6 weeks in those without. And it's interesting, 50% of those at 6 weeks were missed at birth. So that was the net. So in your countries, usually it's 4 or 6 weeks, they go to an ultrasound place, right? Yes. And the pediatricians do them? No, a special center. You do them. Great. Do you ever wonder, do I treat this, do I not? It's a little borderline. Because I imagine that's a hard decision. Because then once you treat them, you have to see them back. So the burden increases. So if it's an alpha angle of maybe 52, but not unstable, I'm sure that is a hard decision for you guys to make.
When we have suspicions and the ultrasound seems normal, we really recommend the pillow for 2 months.
Okay.
And when the baby is...
The Freaka pillow. Yeah.
To be sure.
We usually do 3 ultrasounds until the ossification centers appear, or if it's before, then just 2 is enough.
Yeah. Because you're in Czech, right? Yeah, so I do know because I've talked to the pediatric orthopedist there. He says that they do maybe 5 open reductions in the last couple years. That's it. So it's working. But I imagine, so those hips are easy to figure out, but I imagine it's the mild dysplasia what to do. Are those the ones that I'm doing PAOs on at age 18? And is that pillow, or if it doesn't normalize, normal? So I think the data shows if it's 55 and greater and improving, it will be fine, but nobody's followed them till 18 years old. But if it's not normal, there's certainly no problems with treating it. So that's probably the hardest point. Like, am I going to do it in this case or not? I'd say side on treatment. That would be my...
In my hospital, we do 4 or 5 open reductions every month. Yes.
Where are you?
In Albania.
Yeah, but probably these people have been missed by screening or their immigration?
The problem is that the majority of the children are from poor families that they live so far from the capital.
Yeah, they can't get...
And the follow-up is not so good. Maybe if you see it today and you told them to come after 1 or 2 months, maybe they will come after 1 year. So we are a little bit obligated to put a pillow and to begin that please call out, come to us again.
Yeah. Well, great. So, again, make sure risk factors, uncertainty, or lanibarro negative, you're not really sure. clicks that are sent for consult. It's best at 4 to 6 weeks to avoid the immature hip overdiagnosis. I'll repeat the ultrasound 2 to 4 weeks later. I'm talking to somebody, you guys do this already, and you want to know if the Pavlik harness is working. So here's a breech with a normal exam, and you can see dysplastic. So you want to make a conclusion. Is it normal? Is it dysplastic? Is there subluxation or dislocation? Okay, normal, click, no treatment. If it's subluxatable or dislocatable or dislocated, then we use the Pavlik harness. But if it's subluxed or the normal, you can repeat the ultrasound, and if it's not getting better, I think even treatment in the Pavlik for 6 weeks or the brace is good. Okay, the Pavlik harness has a very high success rate. It depends on the study, but I say 85% if you can get it early. I do weekly follow-up because I want to make sure it's still fitting well, that they don't grow and get ephemeral nerve palsy, which then you have to take them out. Full-time wear, I have them do the bath when they come back to the office. The benefit of weaning, so if it's a normal ultrasound, so you make sure it's in, you confirm it with an ultrasound, and then I follow with ultrasounds, but once it's in, I count the clock, 6 weeks full-time. And then the only question is, at 6 weeks, you get an ultrasound that's normal, then you wean, like 2 hours off this week, 2 hours. Does anybody here in a Pavlik, do you guys wean? Like just maybe nights and naps? You might not treat it. So that's the only question. So I do think if it's abnormal exam or unstable with an Ortolani positive, you have to do the Pavlik for, once it's stable, you have to confirm it's in within a month. If not, you take off and you try something different. But you confirm it's in, then you get an ultrasound to show it's in, and then 6 weeks. Does that make sense for Pavlik treatment? Okay, so what is Pavlik harness disease? Well, when you leave it on too long, or some patients are born breech and their legs are flexed, you have to wait for them to be able to push for it to work. If it's not pushing, they're just going to sit there with the harness floating around. So the indications are dislocatable, dislocated, severe ultrasound, subluxating hips, and stable dysplasia. Relative is you have muscle imbalance, stiffness, marked ligamentous laxity. That's hard to tell. They're over 6 months of age. If they're extremely small, you let them get let them grow better. These are the other options. This is the Ilfeld brace, which we started using again. It's an old brace. We had to convince the brace makers to bring them back because they're good. And then the Rhino brace we also use. Okay, what if they're older? 2 to 3 months, the hip may be stable, so Ortolani, Barlow are negative. So when I get a pediatrician that picks up a 9-month-old with a dislocated hip, I know they were on their game that day. Because maybe the leg was a little shorter, a little less abduction, the Galeazzi is positive, so so this one isn't like this one, those are hard to pick up. Perhaps there's an extra skin fold, which is a soft call, or a positive Galeazzi. So these are older kids that are harder to diagnose, and that's all physical exam. And so when that happens, that's a good finding. If the parent's impression is the kid's not walking normal, or they have unilateral toe walking, one side's longer than the other, or foreshortened externally rotated gait, those are hip dysplasias. So if you have acetabular dysplasia only, well, if they're young, you can consider a brace. Perhaps you get an x-ray, one side the sourcile is up, the hip slightly lateralized, that's when I'll use a brace. Now, if the hip is dislocated, you found it dislocated, or they failed Pavlik harness, then you do closed versus open reduction. And that's very different in Europe than it is in North America because does anybody here do the traction? Yeah. So we don't do it anymore, but you do the traction, you slowly abduct the legs, they come in and you treat it closed. I think that's a great way to do it. In our healthcare system, we've moved away from it. So we will do a closed reduction first, around 9 or 10 months of age, and if it doesn't work, then we go to open reduction. But this concept of traction and let it go in slowly, I think is very good. So you first try closed reduction, but sometimes there's just too much stuff in there and it can't be reduced closed. The ligamentum in these cases is as big as an adult ligamentum, and it's like a rug in the door, and those aren't good enough or it's not stable, and then you need to do open reduction.
Doctor, do you do myotony of the abductors?
Yeah, abductor tenotomy, yeah.
Traction
Well, yeah, so we don't do in North America traction, long-term traction before or as treatment. But it is an art that I still think has a big role, because anytime you open the hip joint, when you go back later, it doesn't look the same. The head's bigger, there's scar tissue, the flow of the fluid in the hip is not the same. So I am a big fan of staying extra articular unless I needed to, and then come later and do an osteotomy and stay outside the joint. But unfortunately, you still have to get, whether you do it closed, primarily would be the first option, or open, you have to get a joint that's medial and sits in there so it can develop normally. Does everybody understand that concept? Try closed. If it doesn't work, then you go to open. The role for closed reduction, well, the need for secondary surgery might be higher in one study in those that had closed reduction. I leave closed reduction for the untreated hip or those with subluxation, because if it didn't work with a Pavlik, it didn't work with the brace, there's a good chance it's not going to go in with the way we do it, which is just intraoperative closed reduction. So I'll wait till 9 or 10 months of age. Sometimes it does and it's perfect and you're done. You do an ultrasound, or you do a injection, but if it's still, or you're doing it and the patient's asleep, the hip's just in and out, you know you have to open that hip up.
What do you mean with not working the Pavliks? I mean, is it not reducible?
Yeah. So after 4 weeks, the Pavlik, the hip is still out.
But it's reducible at this point.
Sometimes yes, sometimes no. And then you try the brace. You switch to an abduction brace, a different position, and that doesn't work either. So basically failed conservative treatment.
So even if it's reducible but it doesn't retain, you go to surgery?
That's very rare. I mean, that's maybe the extreme ligamentous laxity person, yeah.
Do you have an limited age? For example, if the baby is under 18 months old, it's only closed reduction, treated, or?
So I think closed reduction is less effective after 18 months of age. It's probably most effective between 12 and 14 months. The long-term studies, the ones from Torlston, showed if the hip is reduced at 18 months, then 70 to 80% of them are fine at skeletal maturity. The key is to get it in and concentric with a low AVN rate, and that's the best.
Because in DBH, the most important thing is time. As
Yeah.
soon as possible.
So I don't want to take a 4-month-old and try to do a closed reduction, but I do. So if they show up, so either you're very rare see a 4-month-old with a dislocated hip, but if they do, 6 to 8 months I'll try a closed reduction. But I think at 10 months you can do either, so I wait. There's a lot of variation in it. The key point is try to do it closed with Pavlik screening, Pavlik and bracing. If that doesn't work, then you have to reduce the hip. And this is where there's variation. I prefer closed reduction if possible and try to do it before walking age. If it fails, then I do open reduction. Does that make sense? And I like to get the hips in before walking age. Yeah, this is the way it looks, a false acetabulum. Okay, the goals are to reduce the femoral head as medial and concentrically as possible, decrease the chance of avascular necrosis, which means no forceful entry of the hip in, don't force it in. And 2, if they're older, you have to shorten the femur, okay? Decrease the chance of secondary surgery. So it appears that around 15 months is a critical time to perform an open reduction alone. We've done studies on this. So if they're 15 months, 16 months, 17 months, maybe you wait till they're 2 and then you do a pelvic osteotomy at the same time. Because there's just not enough remodeling potential left with time, as you mentioned. There is no conclusive data on the presence of ON and AVN through waiting. So a lot of people will wait till they see the ossific nucleus before doing an open or closed reduction. That data is very mixed, okay? So open reduction. So in cases of failed conservative treatment, closed versus open reduction at 9 to 12 months of age. I mean, you can't get everything. Sometimes they show up at 2, but that's my recommendation. So they come in, they fail everything. I wait till about 10 months of age. Before walking age, I want to get that hip in. I will try closed. If it doesn't work, then I will do open. Some places do the long traction, which we don't do. And spica casting, always. Double spica. And once the hip is in, you get an MRI or CT to confirm. You need to have a confirmation when they're in the spica, okay? So if the patient's walking and they show up, this patient, here on the left, 16 months of age, with my schedule, I'll probably book them 4 to 6 months later and then do probably a Salter with it, okay? Well, there's different ways. There's the Pemberton and the Salter. I'll go over that. So this is the Salter osteotomy, which is an innominate, so open reduction, 24 months old. I didn't need to do a femoral shortening because there wasn't any tension. If there's tension, you do a femoral shortening. What muscle are you solving in that situation? What muscle? Anybody know? So if I do a femoral shortening, what muscle is affected? Or why would you do it? The hamstrings. There's the one things that cross the joint, right? But you cut the rectus. So those are the things, and a little bit of the abductors and the tensor. So if you take a hip and put it in and extend the knee and it pops out, that's too much tension. Does that make sense? So if you cut hamstrings in a dysplasia model, they don't get dysplasia as much because when you extend the leg, it pulls it out. Okay, so when you do a femoral shortening, you're taking tension, but off the hamstrings primarily. That's not a test question, so don't worry about that. I think mine are fairly easy.
Remove the iliopsoas position from external rotation to internal rotation when you do.
Well, we lengthen the iliopsoas because it's an impediment to reduction. Okay, so these are open reductions, and the open reduction, I didn't go into the details. Anterior approach, open the hip capsule, take all the stuff out inside, including the ligamentum teres, which is usually thick, fatty fiber pulvinar, the medial capsule you have to open up. You're looking at the hip, like if you did a little anterior approach, you could do a total hip. That's the kind of visualization you need. You put the hip in, and then the capsule you just sew where it sits, that's what you need to do for open reduction. And then, in this case, I performed the Salter osteotomy. You can see the CT scan shows it's reduced. You can use an MRI to evaluate reduction to show that the hip is in. This is a revision case. So here's age 3. At this age, we needed to do a femoral shortening. And I needed to do in this case, I did a Pemberton where you bend it down versus Salter is cut at the notch. Yeah, we can go on about that. I'm happy to talk to you guys about that later, but just think pelvic femoral osteotomy for the cases that we have here. Okay, so revision cases. Here's a revision case why do you think it's a revision? What's the number one reason? It was never in the first place. Okay, so it needs I go in and it's like there's nothing, like nobody was there before. So it's usually an inadequate medial open reduction. Okay, that's the number one reason. So we put it back in. So residual dysplasia and further corrective surgery. Okay, so should we operate on this hip? Should we operate on this hip? There's a lot of subjective variation. Okay, this is actually one of the best studies that shows the majority of hips treated with open reduction before 18 months of age will not need further treatment, and outcomes are favorable for decades. Okay? So get the hip in medial, no other issues, most of them are fine. A long-term study, averaged 43 years, only 10% of patients needed any further treatment after closed reduction. This is a European study. The osteotomy criteria, if acetabular index is greater than 28 4 years after reduction, so you give it a chance to remodel, then you need to do something on the acetabulum. Does that make sense? Pemberton, Salter. All right, but acetabular development can continue for a while. All right, so I've had patients, let's go back, they show up with this hip right here, and they've been recommended treatment at age 4. And that's fine, but if you watch it, sometimes they get better. And to figure out who gets better and who gets worse is the hard part. So this is like unpublished data. This is just a discussion. I have gotten, unless it's getting worse, and unless it really doesn't change, I watch it till skeletal maturity. And then I can do a PAO. which allows me to put the anterior wall, posterior wall, everything fine. Because guess what happens when you operate on this hip? What do you strip? And you people that do total hips, what is the big muscles that you need very strong? Abductors, right? So when you strip the abductors, you shorten the wing a little bit. It's not as good as abductors never touched. So if I can preserve a hip, and I know it's not, if it's worsening, you need to do something, then sometimes I'll watch them and then wait till they're skeletally mature, rather than stripping the abductors. I hope that's how I view it. So acetabular development is not always predictable. So here's a patient at age 5 that had pavlocarnis treatment. Look at them at age 21. What happened? I've seen that multiple times now. So you have to follow the patients along. And sometimes this hip can turn out normal. Okay, so it's important to observe the hip. So not operating doesn't mean not observing and watching. Proximal femoral growth deformity may be associated with a poor acetabular development. Surgeons may have to be more aggressive with osteotomies later. So this hip is a lot harder to treat than this hip, okay? Because you have a high trochanter. So here is somebody who had treatment. They had a little bit of deformity. So I needed to do a relative neck lengthening and a PAO at the same time. That's a lot more complex. So try to, that's where the AVN, I don't think, AVN that's the wrong term. It's proximal femoral growth abnormality. So when you put the hip in, this keeps changing. Somebody wants me to talk faster. So when you put the hip in, this physis doesn't grow as fast as this physis. And so you get a mismatch. So here's a case where we observe the acetabulum. Okay? And you can see this hip is not 100% normal. And if they hurt, you can do a PAO. But it's concentric. The key point, the hips must be fully reduced for acetabular development. Subluxation always requires treatment, okay? So here's a patient at 6 years of age, was left for follow-up for some reason, and this is what they show up at 18 years. So you could have intervened before then. The other thing is that hip might have normalized too, so you have to watch them. We also now use MRI, okay? Because we can check what the cartilage angle is, all right? So you can see in this hip, there's dysplasia. The acetabular index will be up. The cartilage is good. So that's a hip you might be able to watch. Okay? This is one where, look at the difference though. There's signal in that cartilage and it's slightly up. So if there's signal, even at a 4 or 5-year-old, I'll be a little bit more aggressive because perhaps that hip won't develop normally. Okay? So we'll use MRI. So there's a big debate. Here's one that had a Pemberton. Here's one we observed. I think they're both the same. So it's always a hard decision. Further corrective surgery is, I think, one of the more subjective things. Huh?
What age?
This, age 6.
6.
Yeah. So I moved from Denver to New York. My old partner wanted to do a Pemberton. This family contacted me and I said I wouldn't, and they both ended up the same. But this could have not ended up well, so it has to be observed, okay? So there's different pelvic osteotomies. There's the bending down where you bend it down, and then there's the Salter that moves the whole thing. So here's the Salter osteotomy, which I like in the newborns because the socket is usually smaller. And so you put the hip in, it fits, but it's dysplastic. If you bend it down, all you're going to do is lengthen the leg. So this is the Salter osteotomy, which is easy to do. Outcomes are very good. 54% survival. Well, these are 45-year-olds with osteoarthritis. So if you have a baby hip that needs an open reduction, the chance of that hip lasting past 40s is about 50%. Okay. Pemberton is more of a bending down. You bend down to the triradiate and improve your acetabular index. And here's an example of this. These are for the bigger acetabulums, or the ones that are very copious. Okay, so sometimes I'll do this push-pull to say, oh, there's a lot of space there. I want to do a Pemberton on this one. And then you can talk about the Dega or San Diego. So it's where you bring your chisel. If you bring your chisel from the front and bend down, that's Pemberton. I remember Pemberton, like it goes out like a tongue when you bend it down. And if you come in from the side, that's more of a Dega. Does that make sense? I'd have to show you on a model, but they're all about the same. So the osteotomy in a scaly immature patient may have consequences, as I mentioned. You can damage the triradiate cartilage, you can cause acetabular retroversion, iliac growth may be affected, which would affect your abductor mechanics, okay? So persistent dysplasia, though, we find it still present in about 30% of the patients that have further corrective surgery that aren't PAOs or triples. So here's an example. That looks very good, but you can see when you get to 3D CT, this is what you see on X-ray, but there's nothing covering the front. Okay, so if a hip is still dysplastic at skeletal maturity, a PAO can be performed. It's a safe, it used to be you have all these pediatric surgeries you needed to do before skeletal maturity because there wasn't really an option. Well, there was an option if you moved to Switzerland, but nobody wanted to do this surgery. It was in the 80s, 90s, and early 2000s, but now many of us do periacetabular osteotomies. It's become more of a safe, predictable surgery where you can really place the acetabulum where you want. So now that is the other arm. So again, it's really helped a continuum of disease. Does that make sense? Does anybody have PAOs done at their centers? Yeah, okay. So, a congruent hip may improve naturally. If the acetabulum doesn't completely remodel and there's pain, at skeletal maturity, you can do a PAO. You want to closely observe the hip, okay? Again, the hip must be reduced. So what we found, if we did a closed reduction by 8.5 months of age, that was successful. If we did an open reduction, about 10 or 11 months, that worked. Or if they were older, you needed to do both bony surgery and open reduction, okay? So I just have a few minutes where I'll talk about adolescent hip dysplasia. We won't get into necessarily the PAO, but we'll get into the diagnosis, which I think is important, especially for those that do sports medicine. So dysplasia and instability have a lot of anatomic variation. We use the word instability now, but it's not like the hip is coming out. Classic dysplasia, everybody agrees. You can see this on your X-ray. The hip is the Braken-Shenton's line. It's subluxed. Obvious, a PAO is the obvious choice. But now more and more, especially with screening, those cases are less common, and we see these more mild dysplasia. And a mild dysplasia is an LCE of 18 to 25. A group of us just picked that, not me, but 18 to 25 we now call mild. The problem that you'll see if you're in sports medicine, you have a labral tear and you have mild dysplasia. So let's just treat the labral tear because you have a tear. It has to be treated, right? You can't do anything with a tear. Well, in this room, 60 to 70% of you have labral tears if we MRI'd, okay? So it's like disc disease, you know? You're not operating on all discs that have a little signal change. So it's not really a torn labrum. It's irritated. It could be detached, okay? But you have to understand why it's there. Now, the labrum's important because the nerve endings are in the labrum. So if you have impingement or you have instability and the labrum is under duress, it's going to hurt. Does that make sense? But putting a stitch in it alone is not effective treatment. So you have to treat the pathology, which is either more PT and abductor weakness in most cases, or dysplasia or impingement. Okay, so that's the adult side of things. So we call this a mild dysplasia, meaning to me it's two types. You have a Braken-Shenton's line, the hip is going to wear out, or you have Shenton's line intact and you have dysplasia and it may or may not wear out. So we should ask, what are the pathomechanics of each hip? There is labral and cartilage wound damage and pain from both impingement and dysplasia. The diagnosis and surgery decision should be based on the history and exam and three-dimensional properties. Okay, what is borderline dysplasia? LCE 16, 18. Does everybody know how to measure LCE in here? So it's a measurement. I'll show center of the femoral head straight up to the edge of the socket. Okay, it should be under 25. All right, here you have dysplasia, but no break in Shenton's line, which is this line right here. So it may get arthritic, it may not. So you only treat those with symptoms. So this is the Weiberg angle. It showed there's a linear relationship with so Weiberg showed a linear relationship between the degree of dysplasia and OCA onset, but Cooperman found all patients with a pathologic CE angle developed OA, but there was no linear relationship. So it's like you either have it or you don't, okay? So how do you measure it? This is the angle. You take perpendicular 90 degrees to the edge of the socket. This angle should be greater than 25. Borderline or mild dysplasia, prognosis is better than with subluxation, right? The tires on the car, if it's not fitting well, the treads are going to wear, okay? So unlike severe dysplasia, the goals of treatment may be to treat pain and possibly deformity future. Okay, we do know from this study of osteoarthritis and cartilage, for acetabular dysplasia, each degree in LCE reduction below 28 had an increase of OA of 13%, okay? But let's be real. So if it's a 1% chance that everybody's going to get hip OA, if you double it, it's 2%. So you got to put it in context. We treat those with symptoms. Okay, three-dimensional imaging is important. So factors of hip development other than those conventionally used to measure acetabular dysplasia may be important to determine the natural course. Perhaps, this was back in the 83, new imaging techniques or biomechanical analysis can look to see if it's dysplasia. So coverage may be deficient in more than just anterior lateral. This is posterior lateral uncoverage. For those that you total hips, where's the version of your cup? You know, those things play a role in the natural hip. All right, so this was my old fellow and Paul Boulay, who does total hips. They looked at the three-dimensional deformity of the hip, and they found you could have acetabular anaversion, too much, not enough coverage in the front. You could have retroversion, so posterior lateral uncoverage. You can have mild dysplasia or dysplasia that was treated with rim trimming or labral reconstruction that led to dysplasia, or which is iatrogenic instability, or classic dysplasia, which is your anterior lateral dysplasia. So here's the anterior undercoverage. If you look, see the anterior wall here, the posterior wall here, there's just not enough anterior wall. The lateral CE may be 25, 26, but that anterior wall is not enough to cover the hip, so they have anterior instability. They may have anaversion of the femur as well. Does that make sense? So the hat is on back here, where it should be more on top. This is posterior uncoverage.